Welcome back to another session of the Clarity Education Systems PMHNP Review, brought to you by www.pmhnptesting.com. Whether you're here joining us for the first time or you're one of our regular students at our Wednesday night live sessions, we're here to keep you sharp, confident, and ready for your PMHNP certification exam. Today, we're diving into high-yield clinical concepts that you need to know not just for the exam, but for real-world practice. And as always, we'll break it down, simplify the tough concepts, and apply them to clinical scenarios. So what to expect in today's session? New practice questions with in-depth rationales, test-taking strategies to help you think like the exam writers, and key clinical pearls that separate a good PMHNP from a great one. And don't forget, usually on our Wednesday night sessions, after we finish those questions, we open up the floor for our live Q&A sessions where you can bring any questions about your semester, the review program, or anything else that you need help with. All right, let's go ahead and get started with our first question. So one of the biggest challenges in healthcare leadership is implementing change. Even when we introduce evidence-based interventions, we often face pushback from stakeholders who worry about workflow disruptions, time constraints, or unintended consequences. So in today's case, we'll explore how to facilitate change effectively using organizational change models. So let's get started. The first question reads, a PMHNP is leading an initiative to implement an evidence-based screening tool for depression within a primary care setting. The nurse practitioner anticipates resistance from several key stakeholders, including primary care providers who are concerned about workflow disruptions. Based on organizational change models, what is the most effective initial step to facilitate adoption of the screening tool? The first question answer is A, mandate that all providers use the screening tool and enforce compliance through administrative oversight. B, implement the screening tool in a small pilot group and collect data on its feasibility and impact before wider implementation. C, directly address resistance by emphasizing that failure to adopt to the screening tool may lead to negative patient outcomes. Selection D, focus on educating the staff on the statistical benefits of the screening tool to justify its immediate integration into practice. When implementing evidence-based practice, simply telling people to do something is not enough, especially when there's concern about workflow disruptions. So the key to successful change is stakeholder engagement, pilot testing and evaluation, and adapting implementation strategies based on feedback. So what's the most effective first step? All right, if you chose B, implement the screening tool in a small pilot group and collect data on its feasibility and impact, you nailed it. So let's break it down. So this approach is aligned with evidence-based change models, such as the Iowa model. This recommends piloting changes in small groups before full implementation. The Stetler model, which emphasizes gradual integration of evidence into practice with this periodic and this need for adjustments based on the feedback that come from those that are involved. Cotter's change management model, this advocates for short-term wins to build momentum before full-scale adoption. So why does piloting work? Well, it allows real-world testing before forcing change across the system. It engages stakeholders by incorporating their feedback. It provides data-driven evidence that can ease concerns about workflow impact. This step-by-step approach is far more effective than forcing change all at once. So why are the other answers here less effective? Well, A, this mandate that all providers use the tool, and you're going to enforce this, this forcing compliance without addressing concerns will often lead to resistance and lower adoption rates. Successful change requires collaboration, not coercion. All right, for option C, emphasizing the negative patient outcomes, using fear-based messaging to drive adoption can backfire and make providers defensive. So effective change is built on engagement, not pressure. Option D, educating staff on statistical benefits in order to justify the implementation. While education is important, numbers alone won't overcome concerns about workflow disruption. So, practical implementation strategies matter just as much as the evidence itself. So, our key takeaways here: stakeholder engagement is critical. We want to listen to the provider's concerns. Pilot testing allows um, for these changes before full implementation, and then using a structured change model that leads to more substantial adoption. So, applying these clinical practices, we use small scale pilot projects. We gather data, and then we encourage feedback and collaboration. So, what is the next step then? So, what should happen next here is select a small group of providers to do a trial of the depression screening tool. We monitor workflow impact and collect feedback, and then use that data from pilot programs to refine the tool before expanding its use. So, in this case, we've highlighted the key principle in leadership. Change is most successful when it's tested, refined, and rolled out strategically. If you want people to embrace change, you have to engage them in the process. All right, so this concept will help you see that in both exams and real world, it can improve your PMHNP practice. All right, great job. Let's go ahead and move on to our next clinical case. One of the most important tools in addiction treatment is motivational interviewing, a patient centered, non confrontational approach that helps individuals explore their ambivalence about change. In today's case, we'll discuss how to engage a patient with alcohol use disorder using MI principles, and we'll see what happens. Next question is: a 45-year-old male patient with alcohol use disorder presents for follow up visit after being hospitalized for alcohol withdrawal. He states that he is considering quitting, but is unsure if he's ready. The PMHNP recognizes the importance of using motivational interviewing to facilitate change. What is the most appropriate initial response to engage the patient in the process of change? Option A: if you don't stop drinking, you will end up back in the hospital again, possibly with life threatening complications. Option B: I understand that change is difficult, but I believe you have the ability to take steps towards recovery if you commit to treatment. C: it's clear that alcohol is negatively impacting your life. Let's talk about a treatment plan to get you sober as soon as possible. And option D: what do you see as the benefits and drawbacks of continuing to drink? And what concerns you the most about stopping the drinking? In motivational interviewing, the goal isn't to just tell patients what to do, it's to help them explore their own motivations for change or their ambivalence for change. So, the core motivational interviewing strategy includes expressing empathy rather than judgment, exploring ambivalence instead of pushing them for immediate action, and empowering patients to make their own decisions. So, which response best aligns with these core principles? All right, if you chose D, you're absolutely right. So let's unpack why. So this response aligns perfectly with MI because one, it encourages self reflection by asking open ended questions. Two, it acknowledges ambivalence, which is common in addiction recovery. And three, it promotes patient autonomy, allowing them to express their own reasons for change. But why is this so important? People change when they decide it's time, not when they're forced. Open-ended questions help patients discover their own motivation rather than, resist that external pressure. Engaging them in non-judgmental conversation is going to help build that trust and increase their willingness to explore treatment options. Now, this approach is far more effective than simply telling the patient what they, quote, should, close quote, do. So, why are the other answers less effective here? Option A: if you don't stop drinking, you'll be back in the hospital again. While it may be factually true, using fear based tactics can make patients defensive. Motivational interviewing works by engaging, not pressuring. Option B: I believe you have the ability to take steps toward recovery. Now, the statement expresses confidence in the patient, which is great, but it assumes they are ready for action rather than addressing their current stage of change. First, we need to explore their ambivalence. Option C: let's talk about a treatment plan and get you sober as soon as possible. Now, this response jumps straight to treatment, assuming the patient has already committed to change. And remember, MI is about guiding, not directing. So, our key takeaways here: we want to explore ambivalence first. Change happens in stages. We ask open ended questions rather than giving directed advice. We support autonomy and let patients discover their own reasons for change. Remember, this is part of the trans theoretical model, so the stages of change model. Pre contemplation, not considering change at all, not even on their mind. Contemplation, they're aware of the problem, but they're ambivalent, or they're not ready to make that change yet, and maybe they don't even know why. Preparation, this is when they decide to change and it's going to be soon. Action, they're actively working on the change. Maintenance, we have that sustained progress. So, how can we build on this conversation here? We want to reflect the patient's thoughts back to them. We'll say something like, "It sounds like you're unsure if quitting is the right choice for you. Tell me more about that." Or we can use importance versus confidence scale. That would kind of be the next step here. So, on a scale of 1 to 10, how important is it for you to quit alcohol consumption? What would make the number higher? And then we encourage small steps forward. So, what's the one thing you could try this week to see how you feel? So, this case really highlights a key skill that every PMHNP needs: how to engage patients in a way that fosters change without creating resistance. So, motivational interviewing is about empowering patients to make their own choices. And when done right, it's incredibly effective. All right, motivational interviewing is a skill you will use every single day in practice. So, let's continue on now and move on to the next clinical case. One of the biggest challenges in bipolar disorder management is finding a maintenance treatment that is both effective and also well tolerated. Many patients struggle with medication adherence due to side effects like weight gain, sedation, and metabolic issues. So, how do we choose the best long term treatment for a patient that has been struggling with these concerns? So, let's take a look at today's case and find which best answer fits. So, the case reads: a 37-year-old patient with bipolar 1 disorder presents for a follow up appointment after experiencing multiple manic and depressive episodes over the past 2 years. The patient has a history of poor medication adherence due to weight gain and sedation from previous treatments. Given the goal of long term mood stabilization with minimal side effects, which of the following would be the most appropriate first line maintenance treatment option? Selection A: olanzapine or Zyprexa for monotherapy. B, lithium monotherapy. C, quetiapine or Seroquel in combination with Depakote. Or D, lamotrigine Lamictal for monotherapy. When choosing a maintenance medication for bipolar disorder, we have to weigh two key factors: efficacy in preventing both mania and depression, and minimizing side effects to improve adherence. So, which option here best balances both of these? Okay, if you chose D, lamotrigine or Lamictal, you're absolutely right. So, why is Lamictal the best choice here? Well, it's highly effective in preventing depressive episodes, especially useful in bipolar 1 patients with recurrent depression. Minimal weight gain, sedation, or metabolic effects are also a key factor here because it helps improve medication adherence. Long-term mood stabilization, this is a strong option for bipolar maintenance therapy. So lamotrigine is not used for acute mania. It requires slow titration to reduce the risk of Stevens-Johnson syndrome or SJS. Why are the other options not the best choice? Well, B, lithium monotherapy. Lithium is in fact gold standard for bipolar maintenance. However, side effects like weight gain, tremors, and cognitive slowing can reduce adherence of this medication. It requires frequent blood monitoring, which some patients struggle with. Option C, quetiapine, Seroquel plus Depakote. Now, this combination is very effective in mood stabilization, but both drugs cause significant sedation and weight gain. Metabolic side effects like diabetes and hyperlipidemia increase long-term risks. The patient already has adherence issues due to side effects, so this particular case would not be ideal. So, key takeaways for bipolar maintenance treatment: lamotrigine is best for long term bipolar maintenance, especially for depressive prevention. Consider medication adherence, like side effects, weight gain, and sedation, and that these can be major barriers for the patient. And lithium is excellent, but requires monitoring and can cause weight gain and cognitive slowing. So, how do we then personalize treatment? Well, for severe mania prevention, lithium or an atypical antipsychotic. For depressive prevention, lamotrigine. For mixed episodes, we're going to be looking at Depakote plus an atypical antipsychotic. What would we do next for this patient? We would first start lamotrigine with slow titration to minimize SJS risk. We educate the patient about long-term adherence and benefits, and then we monitor mood symptoms and assess for any breakthrough episodes. So this case really highlights a key challenge in bipolar disorder management: how to find a treatment that's both effective and tolerable. So we always consider patient-specific factors like adherence, side effects, and episode history when choosing a maintenance medication. This is key for both the exams and in practical use. All right, great job. Let's go ahead and move on to our next clinical question case. So, as healthcare providers, we often encounter vaccine hesitancy, right? Especially around the HPV vaccine. One of the most common misconceptions is that only girls need HPV vaccine because they're at risk for cervical cancer. But here's the truth: HPV is responsible for multiple types of cancer. Let's break it down in today's question. The question reads: a 12-year-old male presents for routine evaluation with his parent, who expresses skepticism about vaccines. The parent states, "I've heard that boys don't need the HPV vaccine since they can't get cervical cancer." As a PMHNP, what's the most evidence-based response to address the parents' concerns and support them in an informed decision? Option A: the HPV vaccine is only necessary for girls since they are at risk for cervical cancer. Option B: the HPV vaccine is optional for boys, but it may offer some protection if they choose to receive it. Option C: the HPV vaccine is recommended for both boys and girls to prevent HPV-related cancers, including anal, penile cancers, and oropharyngeal. D: the HPV vaccine should only be administered if the child is sexually active or at high risk for exposure. When discussing HPV vaccination, we need to use evidence-based recommendations to correct misconceptions while also respecting parental concerns. So, HPV causes multiple cancers beyond cervical. HPV-related oropharyngeal, anal, and penile cancers are rising in males. Vaccination provides the best protection when given before exposure. So, what's the best response to educate and engage the patient and the parent? Okay, if you chose C, spot on here. Let's break it down. So the CDC and Advisory Committee on Immunization Practices, they recommend the HPV vaccine for all children, both boys and girls, starting at ages 11 to 12, with the option of beginning as early as 9. So in males, HPV can lead to this oropharyngeal cancer, the most common HPV-related cancer in men; anal cancer, particularly high risk in certain populations; and then penile cancer, which is less common but still significant. We also see genital warts here. This is a non-cancerous but highly prevalent condition. Over 40% of HPV-related cancers in the US actually occur in men. So, boys absolutely need the HPV vaccine to protect themselves and to help reduce transmission. Why are the other answers wrong? A: HPV is only for girls. This is a very common myth. While cervical cancer is well known, and as a consequence of HPV, the virus causes many cancers in males as well. So HPV vaccination protects all genders, not just females. Option B: the HPV vaccine is optional and may help with some protection. Now, while vaccines is technically optional, this phrasing really downplays the importance of. So HPV vaccination is a strong CDC recommendation, not just if you want it as an option. Option D: HPV vaccine should only be administered if the child is sexually active or risk of exposure. This is misleading because HPV vaccination is most effective before exposure. If you want to wait until a person is sexually active, they may have already been exposed to HPV. All right, our key takeaways here: HPV causes multiple cancers in both males and females. The HPV vaccine is recommended for all children starting at age 11 to 12, can also be given early. Vaccination is most effective before HPV exposure, which is why early immunization is key, those primary prevention steps. Framing the conversation with facts and empathy can help address vaccine hesitancy. So use clear, non-judgmental language, provide data on HPV-related cancers in males, and emphasize the long-term cancer prevention benefits. The next steps here would be acknowledging those concerns, explaining the real risks that are associated with cancers in male, and then encourage shared decision making. So, this case really focuses on the importance of your role in education and advocacy. The HPV vaccination is one of the best ways to reduce the burden of cancer, and educate parents is key in increasing vaccine to take place. All right, great job. Let's continue by building on your clinical confidence here and moving on to our next question. Adolescents are notorious risk takers. Whether it's reckless driving or substance use or high risk social behaviors. But why does this happen from a neuroscience perspective? So today we're going to explore how brain development in adolescence impacts decision making, impulse control, and risk taking. Let's break it down. The question reads: a 17-year-old male is brought to the clinic by his parents due to impulsive decision making, reckless driving, and increased risk taking behaviors. He denies any mood symptoms or suicidal ideation, but admits to frequent thrill seeking activities, including unprotected sex and high speed racing. Neuroimaging studies have shown that adolescents engage in high risk behaviors due to an imbalance between different brain regions. Which of the following best explains this phenomenon? Option A: the amygdala is underactive, leading to reduced perception of threats. The nucleus accumbens is hypoactive, leading to impaired reward seeking behavior. Option C: the prefrontal cortex is underdeveloped, leading to poor impulse control. Or D: the hippocampus is underactive, impairing memory formation and learning. So, when we think about adolescent decision making, we need to consider two key concepts. First, the limbic system, the reward and emotion, develops faster in the prefrontal cortex, so impulse control and judgment. This maturation gap explains why teenagers engage in risky behavior despite understanding the consequences. So, what's the correct answer here? All right, if you chose C, the prefrontal cortex is underdeveloped, leading to poor impulse control, you're spot on. So the prefrontal cortex, or the PFC, is responsible for impulse control, decision making, risk evaluation, and planning for the future. But during adolescence, the PFC is still developing, while the limbic system, which includes the amygdala and the nucleus accumbens, is already highly active. This means adolescents have a highly reactive reward system. They seek excitement and peer approval. Underdeveloped impulse control because they struggle with delayed gratification, and emotional overdrive, the strong emotional response overriding logical thinking. So, this mismatch explains why teenagers often make impulsive, risky decisions even when they know the consequences. All right, so let's take a look at those other answers here. Why are they wrong? The amygdala is underactive. Incorrect. All right. The amygdala is actually hyperactive in adolescence, contributing to intense emotions, heightened activity, and social sensitivity. That's why we talk about, our teenagers going through this crazy stage. Option B, the nucleus accumbens is hypoactive. Wrong. The nucleus accumbens, part of the brain's dopamine-driven reward system, is hyperactive in adolescence. This enhanced dopamine release explains why teenagers seek excitement, novelty, and peer approval more than adults do. And option D, the hippocampus is underactive, impairing memory formation and learning. Now, the hippocampus plays a role in memory and spatial navigation. but it is not the primary driver of impulsivity or risk-taking behaviors. Okay, key takeaways here. Prefrontal cortex is underdeveloped in adolescence, leading to poor impulse control. The limbic system, the reward and emotion, matures earlier than the PFC, driving risky behaviors. The nucleus accumbens is hyperactive, making rewards feel more intense in teens. And the amygdala is also hyperactive. This is increasing emotional reactivity. So, how does this affect us in clinical practice? Teenagers may understand risks, but still struggle with self control. Social and emotional rewards, peer approval, excitement, drive many of their behaviors and decisions. Interventions should focus on skill building, structured decision making, and positive reinforcement. So, how can we help in this as educators and clinicians? We educate the teens and the parents. We help normalize adolescent brain development and explain the risk factors. It's not abnormal. This is happening with everybody. So we help them understand. We promote structured environments, so support clear boundaries and safe decision-making strategies. And then we influence and encourage skill development. So we help adolescents strengthen executive function skills through mindfulness, goal setting, and social emotional learning. All right, key takeaway then is teen risk taking equals maturation gap between reward and impulse control. So, this case highlights why understanding adolescent brain development is crucial for you as the PMHNP, because risk taking isn't just about poor judgment, it's a normal part of development. By recognizing these brain differences, we can provide better guidance, interventions, and support for teens and their families. All right, great job on this question. It's definitely a foundational knowledge point on your exam and in real practice. Awesome job. Okay, so at this point, that wraps up the questions. And in our Wednesday night live sessions for our current students, we do transition into an open forum where you can bring questions you have. No topic is off limits. So, questions about your semester, something from the review program that needs clarification, topics you came across in your studies, practice questions that have stumped you, or anything else that's on your mind. This is for our students to have time face to face and have that real experience instead of just always being out in electronic land. Remember, this open discussion, it's valuable. It's an opportunity to reinforce what you've learned and then to tackle any uncertainties. I mean this when I say this. Your success is 100% our priority. So you can access the live forum through the PMHNP student portal, where we continue to work through your questions together in real time. All right, let's end today with a few words to fuel your motivation, shall we? All right, so here we go from Jordan. The only thing standing between you and your goal is the story you keep telling yourself as to why you cannot achieve it. Your mindset matters. The barriers you perceive are often the ones you place on yourself. Challenge those doubts, push forward, and trust in your ability to succeed. And then finally here, the best way to gain self-confidence is to do what you are afraid to do. Confidence comes from action. Every challenge you face, every difficult question, every complex concept, it's an opportunity to prove to yourself that you are capable. You are currently in the process of mastering complex concepts and ideas within a very rewarding field. Keep showing up, keep pushing forward, and keep believing in yourself. We'll see you in the seminars. Thanks for being with us today, and we'll see you next Wednesday at 7 p.m. Mountain Time. Bye-bye.